it's being recorded, so we have a Marquise in the back who's going to record this for us because we think it's an important tool to then be able to share with caregivers at home, being able to email them, social workers, and anyone in the medical community, and people who maybe are homebound who need services but aren't able to get here. So we're trying to kill a lot of birds with one stone today. So again, also know please that we're not implying that you will be going through this roadmap exactly the way it's laid out or needing every service that we talk about. Some of you are at different stages. Every journey is different. So please don't get discouraged or freak out by some of the things that you're hearing. They may not happen or apply to your situation. We're just here to give you that overview. So you will be able to ask questions like Carly said along the way and afterward, but she's going to monitor our time to make sure we get through everybody. Poor Jason always ends up waiting, and we want to make sure he has adequate time. So, and then there are extra copies of this roadmap for you to take with you. It's such a simple tool. It's really not rocket science, but what's important is that you see there are definitions on the back of it for you. It's important to know that there are things available to you that might not be as expensive as what you think. And their goal is to keep people in their homes as long as possible safely. When it gets to the point that that isn't possible anymore, that's what our partnerships are all about, so that we can work together and help you figure out what the next appropriate step is. So with that, don't let my little booklet freak you out either. I'm covering what we do here at the ADRC, so I'm going to just zip through and highlight our primary programs. We're the Aging and Disability Resource Center, or the ADRC. There are several in counties around us, and if you are in a situation or you know somebody who is in a different county than Portage, when we talk about these things, just make sure that you don't say, oh well, Wood County should have that. Describe the program to them. We all might call it something different, and so describe it to them and say, do you offer anything like this where caregivers can come into the house and help us cook meals, or things like that, because we're not all exactly the same, and our format isn't the same either. So just wanted to note that. But our mission is to help seniors. We serve seniors age 55 and older. So the young people in the group, you may qualify for some of our services here. Adults with disabilities, their families, and caregivers. There has been, most of you know our building as the Lincoln Center, and there tends to be a mistaken belief, I guess, in what the Lincoln Center does. Some people think of it as a social building for activities. That actually is our senior center piece of our ADRC. But, and some people think of us as sort of like a large daycare center, like you need to have a disability or something to even participate in our programming and our services. And that's not true either. So we're so much more than that. And the ways that you can learn how we can help you is to either make a phone call to reception, to contact. Oftentimes our first point of contact for you would be an information and assistance specialist. We have 4 of them here, and one is on call every day. So if you make that phone call, or you can just stop in, somebody should be able to sit down with you and at least briefly talk about your situation, and then possibly have to schedule something after that. If you live outside of Stevens Point and you're more rural, you're welcome to join one of our dining sites, and those dining site managers have a lot of information too about services here in the building and what all of the employees actually do here. So Again, my name is Tanya Simmons, and I'm the Caregiver Services Manager. So we're starting with me because, well, this is a caregiver event, but sometimes our paths cross often with these other services in the building, and like I said, these partners. So caregiver support services includes an array of things. So we offer evidence-based classes, support groups for caregiving, one-on-one assistance and support, help with respite services, or help finding you services for in the home so that you're not so overwhelmed as your journey continues. I also oversee our adult day center, which is located in this building. We're a state licensed one-room building for up to 40 people, and we abide by strict staffing ratios. So once you have the preliminary paperwork filled out, you're welcome to bring the person you're caring for by, once a week or every day of the week, or whatever you arrange with the supervisor of that program. Let's see, what else? The Dementia Care Specialist program. So Carly is our Dementia Care Specialist, and we work closely together as well with referring families back and forth to each other. I help caregivers of all kinds. It doesn't have to be because of a dementia of some sort. When that happens, where we start talking about dementia, I would give a referral to Carly, and then she's the expert on ways to help you communicate better, family dynamic things, understanding the disease and the progression better, just being a partner with you throughout the course of that disease. She can provide memory screens. Those results can remain confidential, or you can ask her to share those with your healthcare provider. She provides virtual dementia tours, so they're like simulated dementia experiences, so you can gain more empathy and understand what a person with dementia is going through. She oversees our Safe and Sound program. It's sort of like a local Silver Alert programs, a Wanderers program. It's a free service. Provides memory cafes. They're like social gatherings for people with dementia and their caregivers, because oftentimes you start maybe losing friends, or your life changes so much you become more secluded and isolated, and that's not good for anybody. So she facilitates those on a monthly basis. And she also helps with family. A lot of times there are family dynamics that occur throughout caregiving. Somebody's always there to tell you, how to do something better or whatever, and she can facilitate like family conversations, and then also provide some one-on-one caregiving advice like I do. Going back to those information and assistance specialists, when you first contact the front desk, I had said, that they might be one of your first points of contact. They're really important to talk with. Your information gets put into our system, and they try to help you navigate through services in the community as a whole. So whether it's, and it's all confidential, so it's very individualized. They know the scoop about local housing and all of your options and in-home services, and they also can take it as far as talking with you about your long-term care needs, not just the person you're caring for, but for yourself as well, and help do assessments pertaining to that. So they will do a functional screen, see, whether it's in your home or you come into the office, and they'll talk with you about what your person is able to do for themselves, and then look at your financial situation too, and let you know what might be required to take care of, how long it might take, and what that picture brings. It helps us as caregivers, we're overwhelmed a lot of the time, and just being and feeling a little more prepared and having a plan. It doesn't even have to be a set plan, but it might help you lessen some anxiety if you're coming up with options. We have benefits specialists. Disability benefits specialists serve people between the ages of 18 and 59, and then we have elder benefits specialists serving people 60 and over. To sum this up in a nutshell, you might need them if you want to know more about public or private benefit programs, when you need help applying for benefits, when you've been denied a benefit, program, or service to which you think you might be entitled to. And then a lot of you know about the open enrollment period in the fall, and the benefit specialist can help you discuss your Medicare supplement plans, your Part Ds, and I'm leaving it at that, Maria. Our loan closet is in the basement here in the building, but they help with, people will donate items to the loan closet throughout the year, and we provide short-term equipment usage of specific items so that you can test them out before you might need to purchase something, or if you know it is, like I said, short-term, you can just use it. The items are looked at, they're repaired. If something is junk, we do just get rid of it, but we clean it up, and it's on the honor system. You bring it back when you're done with it, and sometimes that's the first point of contact people have. You can be any age to use it, so even though I mentioned 55 and older in the building, that's not the case for the loan closet. And Project Lifesaver is another Wanderers program that's so important to know about, but don't wait for your person to wander. We hear too often that people say, well, they're fine now, they haven't tried leaving the house. Well, winter's coming up. You don't want them to, all of a sudden decide they're going back to the home they remembered from 40 years ago. So Project Lifesaver, there's a small fee, I think it's $15 a month, and it's radio technology. I think they wear like a bracelet or something, and it's a great locating tool with law enforcement. Our nutrition program, I mentioned the dining sites. We have dining sites here, Roshold, Junction City, Amherst, and Plover, all open on different days, but the front desk can help you with that. But if you are interested, one of the big things that they do, which I love, are their home delivered meal program. Okay, so if a caregiver is overwhelmed and you're thinking, it would help if I had meals delivered so I don't have to worry about that. Our home delivered meal program is just like the Meals on Wheels program that you all have probably heard about. It's just that Meals on Wheels covers a different territory. We deliver more to the rural areas. Right, Cindy? Yeah. Okay. And then, of course, the Lincoln Center that you are familiar with. We have exercise classes, craft classes, all kinds of things to get you involved. You could bring your person to the Adult Day Center while you attend a class. Just your social life is just as important to try to continue to keep going. And then a lot of evidence-based classes as well, and then transportation services. We don't offer transportation services out of this building. We fund the transportation service out of Central Transportation. So a lot of people aren't aware that they cover Stevens Point and rural areas, that they can take you to nutrition dining sites, our building, the Adult Day Center, volunteer workstations, and medical appointments, just to name a few. So if you're having struggles with that, let us know. And then also, lastly, volunteer programs. We have a program that can help you remain engaged in the community. We have home delivered meal driver opportunities, office and clerical stuff, food pantries. If you're a knitter or crocheter or crafting person, Lindy is the person to ask for at the front desk for that. That was a lot. Okay, thank you.
You did great.
Thank you.
Hi everyone, I'm Jessica Klender. I'm the General Manager of Home Instead. Home Instead is a non-medical home care agency. We can provide hands-on assistance with all activities of daily living as well as instrumental activities of daily living. I do not require a doctor's referral in order for you to start services. All you have to do is pick up the phone, we'll have a conversation about what's happening with your loved one, and we'll move forward from there. Unfortunately, because I am non-medical, I am unable to be billed out to Medicare or Medicaid at this time. They do not view us as a billable expense. However, our goal is to maintain your independence at home as long as safely possible. Often we co-care with home health, with hospice, in order to maintain your loved one's independence and dignity and safety. So they handle the medical needs on that aspect. We are primarily private pay, however we do accept long-term care insurance, which is a rabbit hole of itself, so if you have questions on that, call me later. We also work with some forms of managed care organizations for reimbursement as well. I think that wraps up everything.
Yeah, and if I can touch on it, bring it back to
Great, I'll hand it off here.
So I am Samantha Morgan. I am with Compassus Home Health. So home health is the skilled side. So as Jessica said, she's the non-skilled side. So we work well together. We partner together on that aspect. So when I say skilled side, what that generally means is it's skilled nursing, physical therapy, occupational therapy, social worker. Depending on the area, we do have home health aides. But that's generally when we go to the supportive home care side of things, because we are physician ordered. So we can't do anything, we can't come into the home without an order from a physician. Now generally, when you look at insurance, they'll say, well, that's not medically necessary for a shower every day, right? Most of us want a shower every day, but it's not medically necessary. So they'll only give us the opportunity to come in twice a week. And then if you would like more, that's where we transfer it over to supportive home care to get you those assistants for other days. Physical therapy, occupational therapy, obviously, those are rehabilitation. It is a short-term program. So home health is not a long-term care. We do intervals. We look at, there's reassessment every 30 to 60 days, and then you might be discharged. And then maybe something happens to where then you can come back. But it is not a long-term program that we have that we can assist with. I think I covered everything. Usually it's a smoother process. Is there any questions on home health or what home health entails?
Can you talk about if there's minimums and what that schedule looks like for both of you guys?
So for home health, usually what happens is the nurse will come out and they'll do a full body assessment, and then the therapist will come out as well and do an assessment, and that will generally make their frequency, as we call. So generally it's 2 times to 3 times a week, depending on the needs and what the physician orders. Wound care is generally 3 times a week. Therapy is usually 2 times a week. So in those terms, they're flexible, they work with you, the nurses come to the house and they provide that service in home. Supportive home care?
So with supportive home care, we also do an assessment. It looks a little bit different, obviously, because we are non-medical. The goal of your assessment is to develop a detailed plan of care of what your expectations are for that caregiver when they're assisting you at home. As far as minimums, I have 2 different programs now. I have something that we call block scheduling, which is a reoccurring schedule with set times and days. We build out your care team from there. That minimum is 4 hours to 24/7 care. So we can provide assistance in the home round the clock if necessary. That's your wishes. My second program, which is new, I just rolled it out this month. I'm calling it our Pop-In program. So that is a program designed for adults who are in between. They don't technically need block scheduling yet. They don't need that much support in the home. However, they could use assistance with a shower a few times a week, and those pop-in visits are 1 to 2 hours, anywhere from 1 to 3 times per week. I think I covered it all, Carly. Okay.
Question for you. My sister had an operation a couple of weeks ago and the doctor authorized home care twice per week.
Mhm.
They were supposed to come to see her on Friday. They never did. Finally, she called the doctor. She had to go back to Marshfield to get the dressing changed. And when they finally talked to the home care, wherever they were, they said they were having issues because of labor shortage.
So I can only speak for Compassus. There is not staffing issues, there's scheduling issues. So we have seen an overabundance of patients who were in the hospital who have discharged, or were in a skilled nursing facility and discharged, or were in assisted living and need the help, alongside of individual referrals that have come in. So when we talk about we need a physician order, sometimes it's a struggle in between just because we're different entities, right? So I'll need a order from the physician, but if the physician is in with patients, I don't get it till 4:30, I can't schedule it. So there's different ways about that, and there is a delay in start of care when that happens, and I apologize that did, even if it wasn't us, because it's frustrating and I know that. But it does happen because there's an overabundance of need for home health. So whether there's 6 nurses, they have a schedule that could be 3 times a week for each patient, you're already filling up their day, right? So we have to try to figure out scheduling in that aspect, and it all depends on when the referral comes in as well. If it comes over on a Friday, our offices are closed, we don't get the referral till Monday, that's already 3 to 4 days that she's not gonna be seen. So when I go in and I talk to the physicians, I have conversations about when is it appropriate to send a home health referral. If they have an inkling of, okay, I'm gonna send one, give me a call, I can get them on the schedule and we can figure it out prior to having the actual documentation. So there's a lot of different things that can delay a start of care. But right now, for Compassus, I know that it's delay in start of care due to the overflow of patients that we've had. So, like I said, I can only speak for
But
us.
that's just not just Compassus, everybody has
Right.
just.
Yep, but I can only
everybody's
speak
working
for
with
mine
the
because
delay.
that's all I know,
Alright,
right?
but they'll-
So, so in that sense, there are sometimes where there are delays.
I work with Aspirus, but our services are available at many healthcare facilities like Marshfield and all of that. But advanced care, you guys might know it as an advanced directive or power of attorney for healthcare. It's a form that states who can make medical decisions for you if in the future you're not able to make them for yourself. The important piece is that we are not a next of kin state. So what that means is your spouse, your adult child cannot automatically make medical decisions for you if you're not able to. You need to, if that's who you want, if I want my husband to be able to make those decisions for me, I need to get that down on paper. And we encourage you to use what's called an advanced directive. The good news is that Aspirus and Marshfield and other facilities offer free assistance with that. And I love that because I don't like to spend money and I believe in the product. So it's a win-win for everybody. So you can contact either Aspirus or Marshfield, set up an appointment. We can help you over the phone. Aspirus offers in-person appointments at our offices. We can sit down, help you go through the entire document, help you get it witnessed, scanned into the medical system, and also make extra copies for any of those that you want to have copies. If you don't have a power of attorney for healthcare and you're not able to make medical decisions, unfortunately what happens is then the family has to hire an attorney and then go to court and become your guardian. And that means lots of money spent. It means time away from your loved one. They're already ill, they're already not able to make decisions, you're worried about them. Last thing you want to do is hire an attorney and have to go to the courthouse and spend time at the court. So this is pre-planning. I say it's the cheapest insurance policy you can get. Because again, we don't charge for this service, and the document is good anywhere in Wisconsin. Even if it says Marshfield Clinic or Aspirus on there, it's good anywhere in Wisconsin. So that's good stuff too. Any questions for me at all?
Does somebody have to have an appointment with you to set that up?
Thank you, yes. So the best way to do that is to set up an appointment. Here in Stevens Point, I'm at the former St. Michael's Hospital, and I'm there 3 days a week usually. I'm in Wisconsin Rapids 1 day a week. I do have coworkers in other areas throughout Aspirus system, but if you just call, and our phone numbers, I have little brochures over there and some advanced directives. You just call that number and we will get you set up. And honestly, sometimes I see people the same day or the following day. It's not like calling a physician. You can get in pretty quickly. Okay, any other questions or?
And I think another thing, and I think you and I have mentioned before, is that once they're met with you, you then can put it in their electronic medical record as well?
Yep, so let's say you come and see me at Aspirus, and you see a Aspirus providers, and maybe you see a Marshfield provider. I will fax it over to Marshfield, and I will get it scanned into your medical record at Aspirus. The good news is that that electronic medical record is seen by all of our Aspirus facilities. So if you end up in the ER, your document's there. If you go to your primary care over on Vernholm Way, your document's there. That is the beauty of electronic when it works, right?
I do have a question.
Yes.
If they're in the hospital, or if a patient's in the hospital and you notice that they don't have, or is their staff geared to getting a hold of you guys to come up and do that? I mean, if you're in the same, obviously, Aspirus, but does that work as well?
Sometimes it works. So she's asking about people that are in the hospital, and we note that there's no power of attorney for healthcare and file. The care coordinators will talk with either the patient themselves or their loved one. I, behind the scenes, will look in. I have access to the Marshfield system that I can look for your advanced directive there, or in our old system when it was Ascension. And if I find it, I pull it over, get it on your medical record. They don't even know that I do that, but I do, because it's that important. But sometimes I am able to go up onto the floors and see patients, so it's kind of hit or miss, but they oftentimes will give you that advanced directive, and right on the front page, it's a blue colored page, our phone numbers are on there. And again, you can call and we'll get you taken care of. Yes?
What happened, there's a lot of people that are going on vacations. What happens if someone has a medical event where they need that person to do a directive? You said ours is only good for the state of Wisconsin. What would happen if they had a major event down in Florida or something like that?
Sure. If they have a Wisconsin document completed and they're in Florida, it will be honored up until the point that it doesn't meet Florida's state statutes. So, the good thing is, the good and the bad is Wisconsin tends to have more specifics on their document, more requirements. For example, we have people from Michigan that come to Wisconsin for care, again through our Aspirus system, for example. Michigan does not require the question about giving your healthcare agents permission to determine or to sign a person in for placement, let's say nursing home or community-based residential facility. So if the patient ends up from Michigan in Wisconsin and they have a surgery and now they're not able to make decisions for themselves and they need to stay in Wisconsin, we would have in the past had to do guardianship. What we did was we added those specific Wisconsin questions to our Michigan document so that we can avoid that. So generally, most states do not require the placement question or the tube feeding question. So to go full circle, if I were to end up in Florida and I had a medical event, I have a Wisconsin document. My husband is my first agent. He would be able to make medical decisions for me. Now, if there might be a little specific thing where if I need placement in Florida, but again, if I need placement, I already have that down that he can do that for me. But most states really work with you. They want to do the best to honor your wishes. Did I answer your question? Perfect, good. Any other questions? I bet you I'm over my time. Oh, I'm good, okay. It's an amazing topic. You assume your spouse can make those decisions for you, but they can't.
And can for your children.
Yeah, that's the other excellent point. So anyone 18 and older should have these documents. And I used to be a trauma social worker, so I used to have to tell spouses of 60 years you can't make medical decisions for them, or parents of a 20-year-old, worst day of their life. And then I have to give them even more bad news. And these documents, you can update them as needed. I'm probably on my 11th document. I work with people, I learn from them, so I keep updating mine. Three of my kids, when they were 18, they had their document done. Now some of them are married. I had them redo them because they might want their spouse on there, right? But as life changes, as you get a new diagnosis, as someone passes in your family, check your document, make sure they're not listed as an agent, or think about what they went through, and has that changed what you want for yourself? So our wishes change. When we get to be 110, we may not want CPR, right?
So before you hand that off, I just want to touch base because I hear this a lot in the home health field. Emergency contacts are not your advanced directives. So a lot of the times we get questions about that. Well, I'm an emergency contact. I understand that, but that's not your advanced directive. So there are differences in what you're putting down. So thank you.
Yes, and
No, and that brings a quick other point is, just because someone's named as your healthcare agent, if the document has not been activated by 2 healthcare providers, that person isn't your healthcare agent yet, okay? So that's an important piece too. But ask questions, ask staff, hey, I'm listed as my mom's healthcare agent. They may say, is it activated? No. So that doesn't mean you automatically get contacted yet. That's still up to your mom to make those decisions.
I think we're gonna start with this next one. Okay.
Hello? Okay. My name is Ashley Netzer. I own Home Point Real Estate. I'm definitely kind of the oddball in this group. I'm surrounded by medical professionals. But the reason I'm here is, A, I like to be connected to everybody in this group because I get questions all the time by some of my clients that are looking at selling their home or maybe their parents' home or things like that. But also, some of these road stops might cost some money, and you might need to know how to access some of your money, or just have a general idea of how much your home is worth. So as you have discussions with your kids or your caregivers, and you're kind of going over wills and scenarios, you just know what that number might be. So I don't mind coming into the house, kind of looking through everything, saying, okay, I think it's worth X amount of dollars. And I don't care if you call me again 10 years later and think about selling then. I'm not here to talk you into selling your house today. It's that, again, some of these things, you might need to access some of your assets in order to reach them. And I want to be helpful in that and help you just kind of understand where your finances are at as a total picture. Nikki will kind of go over much more detail of your finances. I'm just a little piece of it. But again, like I said, it might be one of your largest assets that you have, so you might need to be aware of how much it's worth, so.
Hi, my name is Nikki. I'm a certified financial planner, so anything that's going to impact your finances, that's what I deal with. And I guess Ashley kind of gave me a nice lead-in. One of the best things you can do is have these conversations with the people that are important to you, with the next generation, about what you want to happen to your house, where these important documents are, who are your financial power of attorneys, who are your medical power of attorneys. Sitting down and having that family meeting when you're well and everybody's on the same page is important. It needs to be updated. She's on her 10th document, I'm only on my 2nd, but you know, laws changed at the end of 2019, so I called my estate planning attorney and I said, hey, do we need to make some changes? Well, we didn't need to make changes to the law, but we needed to make changes because my husband's and my situation had changed. So it's important to keep those documents up to date, and at that point, we removed my father from my medical power of attorney and added my brother. So again, needed, and that was at my father's direction. I'm aging, get your brother on, he's established. Have to let my brother know.
Right.
So that's the estate. So when you come in and you sit down with a certified financial planner, the first thing we're going to look at is anything that puts your finances at risk. And then we're going to make sure that you have finances available to you. The last piece we look at is the investing and how to grow your money. But the first things we do is make sure that you have what you need for income, that everything is set. So insurance policy reviews are a big thing that we'll do because everybody buys insurance with a purpose, and then nobody looks at it, the insurance agent doesn't contact you again. 20 years later, you still have this policy, you don't know why, you really don't know what it does, you're paying on it because it's what you've done for the last 20 years. But do we need life insurance now, or would long-term care insurance make more sense? And sometimes you can change the policy or use that benefit. So those are all things that we sit down and look at. And then also, if it does get to the point where you're going to need care or you're going to need funds because you're going to have somebody coming into your house, we take a look at what you have and we'll talk with your estate planning attorney and we'll talk with your accountant. And we'll determine where to take the money from, how much this is going to cost us in taxes, and how, honestly, if we can afford it, or what might be our better options. I think most people here know you have to privately pay for 2 years in a nursing home before you're guaranteed that spot if you go on to Medicaid. Otherwise, Medicaid can place you anywhere. So you might be from this area, but you might be placed in a Medicaid facility 2 hours away. And maybe that's not convenient. So just things to consider. Any questions? All right, we'll move on.
Moving along. I am Cindy from Portage County Healthcare Center. I do not like talking into this thing, I'll be honest, it's distracting me already. But here's the deal. We are a skilled nursing facility, and in all honesty, I feel like assisted living and nursing homes are hand in hand. At one point, I could be first, he could be second, he could be first, or, and I could be second. So it really just depends on where you are in your life. That roadmap is exactly what Tanya said. It is not exactly how it always goes, but it's a good way of getting things prepared. In Portage County Healthcare Center is considered a skilled nursing facility, and I always want to make sure you guys get the best definition of that because people don't understand, well, can't I just go there? I pay, I'm on Medicaid, I pay taxes, I do this, can't I just be there? And that's not how it works. Skilled care refers to skilled nursing or rehabilitation services provided by licensed health professionals like a nurse or a physical therapist or any health therapist and or a doctor. So that means you have to have a skilled need to come to us. Custodial care means daily cares, helping get dressed, things with your medications. That's not a skilled need in our facility. So years ago, you could come to the facility under Medicaid or a managed care like in Coosa or Lakeland, and you could come there and you could stay. But things have changed, as they always are changing. You now have to have a skilled reason to stay with us, and that's just the way it is. So if you aren't skilled, we would look at looking to an assisted living. Most of my referrals come from the hospital, obviously. They can come from anywhere. They can come from home. They can come from hospice as a referral from home. They can come from the emergency room. But we do take the different entities as far as payer sources. There's Medicare, and then there's managed Medicare, such as Advocare, Network Health, Anthem Blue Cross. Those are managed Medicares, and they run quite differently than true Medicare or straight Medicare and a supplement. We also take private pay. We also take long-term care insurance, and those are little things that have to be straightened out at first, but we look through all that paperwork if you have it. And then there is also, I think I said private pay as well. Now, we are a small facility. We are not like we used to be. I know a lot of people don't understand how we can only take so many patients anymore, but COVID has made a very difference in our life, and it has changed staffing situations. But at Portage County, I still like to talk and let everybody know we still have the same CNAs and nurses. We do not use agencies for our facility. It may have cut us from being able to take more patients, but in all honesty, it keeps us at a level of continuity of care when they do leave us, from the hospital to us, to an assisted living, to wherever they go, but it also keeps a high quality of care. We're not perfect. Everybody makes mistakes, and we're not as great as one person might think as the other, but we are very geared to working with the county and the people that are in here in our facility and the people around us in the county to make their stay a good stay. There's so much to say about skilled nursing and my step in this, but it's just easier to honestly have you call if you are in the hospital. Your case managers will call. I will work with them financially as to where you need to be or where you're at and how the payer sources are going to work prior to you coming. Our social workers will work with residents and family after or while they're there with us, if they're going to an assisted living or not. We work with all home health people big time, about going home and things like that and getting set up. There's just so many different things that our facility can and cannot do, but for the most part, we're the middleman before you might go home or you might go back to or leave an assisted living, and we will work with whoever we need to work with to get you there. I feel like I'm not saying enough, but I'm saying enough.
I think a lot of it's just individual questions, and I think you hit on that, is if you have a question, just to contact me.
It is, and I'll get a lot of people that will contact us and say, I need to put my mom in there. We got to get her in there soon. I can't do this anymore. If I'm talking to a family member that I start asking questions and I don't feel that they're appropriate for our facility, I will certainly get a hold of home health, or I will tell them, hey, check with ADRC. The first thing I kind of do is go to the ADRC. They got ADRC. They have a lot of stuff, a lot of good information. Okay, and if not, I'm like, I will send them the packet of information of all the assisted livings in the facility. I encourage people to do tours. Check it out. Go check it out. See what's out there. Like pre-planning. Make a decision if you say, hey, I want this one, or this one. But have your top 3 assisted facilities. Have your, top 2 or 3 nursing facilities, because you can't always get into any of them, and you might be an hour away. That's just kind of how things are going. It's not a great place to be, but we will do what we can to try to get you in. And again, I will try to as well help anybody out without saying, oh yeah, come to us. Yeah, you need us, and we don't believe in a head in the bed. We believe in quality of care, and we will always go down with quality of care in our facility, and we will help you get, again, where you need to go. I guess that's it, but I do have a question. Can I ask now, or should I wait till the end? Huh?
Wait till the end.
I don't want to. Did you hear that?
She has the microphone.
As a matter of fact, I do. Now I got a hold of it. No, I'm sorry. If you need anything, give me a call. Seriously, give our building a call.
Is it my turn?
It's your turn. Yeah.
Tell them that.
Yeah, thank you. Put it on, put it on.
I'll go, Jim, go. I'll be
Yeah.
quiet now.
All right, thank you, thank you.
My blessing I have.
My name is Jim Miklish. I'm the Director of Community Relations at the Lodge at Whispering Pines and Whispering Pines and Clover. Assisted living communities, lower level and higher level assisted living communities. I think typically you work with two type of residents, short-term residents and long-term residents. Short-term, you might hear the term described as a respite stay. In our community, it's a stay between 10 and 27 days. Other communities, it might be 2 days to 30 days. Different communities have different rules. I think the person in a respite stay is usually a loved one that's at home and maybe family's going on vacation and they just don't feel comfortable with the loved one being at home, and they'll put them into a community for that short-term stay. Also, it's also a nice way to see if you like a community. When you come into a community, typically you don't sign like a year lease or a 2-year lease, it's a 30-day notice. So usually it's just a nice way to come in and maybe to see how the loved one likes the community. And then you have long-term residents in a community. Typically, someone who's coming into our community, and like Jessica and Samantha had said, you always want to keep your loved one in the home as long as possible. When that can't happen, then a community is a really nice option at that point. I think typically they'll check a couple boxes when they come into a community. Safety issues at home is a big one. That could just be stairs. A lot of times it's into your garage and a couple stairs into your home, or multi-floor living. Some people that don't have walk-in showers, the loved one is still putting their foot up over the tub. That's a big safety issue. They'll check the box of level of care, where it starts to become a little bit too much for family. It could be, the hygiene, bills aren't being paid, medications aren't taken properly. They might not be eating properly. So that level of care starts just getting a little bit too high for family. And then it comes down to socialization and activities. Lots of times the loved one is at home by themselves, and family checking on them, making phone calls on them, but they're at home by themselves a great majority of the time. And so I think those are the characteristics that you see in a community. It's always good to go out, as you've heard up here, to go and look at communities just to see what you think of the community, and then bring the loved one in. And they can make those decisions of where they feel comfortable in the community. I will say this, typically it is a process and it's never easy. The first 2, 3, 4, 5 days when a loved one comes into the community, it's very difficult. We usually see it takes about 30 days for them to really find a nice routine where we can keep them in that routine for as long as possible at that point right there. So 8 out of 10 families I work with, the loved one does not want to come in, the family would have them in yesterday if they could. And so it's difficult. Those same people that don't want to come into our community 6 months later in the community always say, I wish I would have came in 6 months earlier, as you see the community go out that way. So it's a process, and you never want to lose trust in your loved one at that point right there. Questions?
For assisted living, a person that doesn't have the financial status where they have Medicaid financial aid, do you accept that right away, or do you refer private pay first and then Medicaid?
Yeah, so we have a wait list for both private pay and managed care organizers in our community. Lots of times it's a business, so you want to work with the private pay people typically most of the time up front, but we do accept the managed care organizers, inclusive Lakeland Care, in the area here. Yeah.
Thank you.
You bet.
Can I add to that?
Turn your mic on.
I'm just stealing.
Well, I am just gonna add to that, because like he says, it's not that people aren't compassionate that you can't get in. It's that, you know, I used to know somebody that worked at Portage County, you know, it costs $400 a day per resident for them to break even. Well, Medicaid reimburses 85 to what, $125 a day? So you cannot maintain a facility that's going to take care of your loved ones at that rate. This is truly something you need to plan for. I don't know if anybody here has long-term care insurance. The old traditional insurance has pretty much gone out in our industry, and we're using hybrid products now because they completely missed the boat on this. The underwriters and the actuaries that figured out this pricing. I mean, I have clients getting 30% increases to their long-term care premiums, and not like every couple of years, sometimes years, consecutive years in a row. This is an insurance that, it's not like life insurance where most of the people on a 20-year term policy aren't dying. Like, most of the people do end up using this to some extent. If you want the care, you have to pay for the quality that you're going to get, unfortunately. Well, not unfortunately, that's the way it is. But, you know, look at it from that end. I hope that helps. Hopefully that helps you feel better. It's not that they're money grubbing. It's literally the place would close if they only took medication.
You know, some places,
Other places, I mean, we've seen it happen.
some places have like a year and a half private pay before they'll accept Medicaid.
2-year private
Some of
pay.
them do too.
2 years is what I've heard in town.
Yeah.
Pretty much, from clients.
And I will say this, typically our rule of thumb in our community is 2 years. We're a little different. A family in Stevens Point owns our communities, and so we're not black and white on the 2 years. We're always more than flexible to work with families. You know, if it's somewhere in that area, we can always be flexible in our community with that. But I think that's pretty much what you get as a 2-year private pay, and then you look from there.
There are some that don't require that, but again, tour and kind of make decisions based on where you feel comfortable. There are some places that would not require that. Putting on that old hat.
Yeah, that's right.
Is it my turn? I'm going to try to get through this list, Carly, without having you to ask me anything. I wrote things down. So I'm Amanda with Compasses Hospice. We kind of tend to be the elephants in the room. I'll say both of us over here. For me, I can say it's because there's a lot of misconceptions about hospice. So I always kind of start off going over a couple of those. One of them being that if you come on hospice care, all your medications are taken away. That is not the case. If you have medications that you're taking to actively treat something such as cancer, for example, you would not be receiving chemotherapy, radiation, things like that. However, many of your daily medications that you would still be taking is a conversation with the nurse when you come on a hospice service. So one big misconception. Second big misconception is that if you come on to hospice services, you'll pass away within a couple days. Of course, we do have scenarios where that happens. However, to be appropriate for hospice care, they say somebody would have about 6, is this way too close? It feels really close to me. Okay, it's very echoey. Maybe it's that to everybody else too. It's distracting.
Told you.
You're not wrong. So they would say that someone would have about 6 months life expectancy if their terminal diagnosis would run its natural course. That being said, even with that 6-month time frame, we have had people on service for several years. So we've had people graduate hospice, as in they came on, they did better. They gained weight, or a certain scenario that they had improved. We've had people come on where they haven't gotten better, but they haven't gotten worse. They've just kind of maintained where they were eligible for hospice. So we'll have a longer stay with those people as well. So those are 2 misconceptions. Third would be that they don't treat anything once you're on hospice. They will treat things acutely, such as like UTI, pneumonia, things like that. Again, it's a conversation with your hospice care team. But 3 misconceptions, and then I'll kind of wrap back now that everyone is listening to an actual hospice conversation. There's 4 main diagnoses for hospice eligibility. That being said, there's many diagnoses that they'll look at, but typically when we have people coming to us, we'll see they either have a cancer diagnosis, an Alzheimer's diagnosis, COPD, or a CHF diagnosis. We will have a conversation, a consult with those receiving that diagnosis. Some people, they hear that, they kind of know how things will progress, and they're open to having a conversation earlier. So as you've heard a lot of us up here mention, you're not in a crisis mode making decisions. You've had a conversation, you're kind of aware of what the next steps will be. That being said, just like everybody up here, we get calls in the emergency situations too, and I, myself personally, or my team, or a hospice team, will come meet you in the emergency room at the hospital, wherever you may be. We are Medicare paid benefit. There's not an age limit on hospice, so you don't have to be 65. So that being said, if you would not be Medicare eligible, we are paid privately by insurance. It's a billable service. Referral can come from anywhere. So I had mentioned emergency room, a hospital, primary care provider. Any of these folks up here could call us. You can call yourself. If you do call yourself, or if it's not a medical professional calling, we do need a medical or a doctor's order as well. We can get that for you. If we're not able to reach your primary care provider or a doctor that you work with, we have a medical director who will make that order for you. Team consists of a registered nurse, a home health aide, a chaplain, and a social worker. Registered nurse would do any of what we'd call skilled care, so kind of the things Sam was touching on, not therapy-wise, but skilled care. We would handle symptom management, medication management, a variety. Everybody has a different journey, so everything would be specific to them. Home health aide, we would provide, again, we would not take the place of Jessica over, our friends over at Home Instead. We don't do 24-hour care, but they would come in if you needed a shower, oral care, nail care, things like that. We're not a 24-hour service. If you would need something like that, another part of our team is our social worker. They could either help you get in touch with one of our friends over at the assisted livings. Jessica and her team over at Home Instead we work very closely with. We will care for you wherever home is to you. So if it's at your residential home, we have contracts where we can care for people in some instances right in the hospital. If they're not able to safely go home and their journey is going to be very short, we can, in many instances, care for you in the hospital, your residential home, skilled nursing facility, assisted living. And as far as our admission process, it's just requiring, you don't have to talk with me, you can. Otherwise, we can send a nurse out. She'll come, again, wherever home is to you, do an assessment. That's where they come up with your care plan. So again, we've all talked a lot about care plans. The care is always going to be very specific to the person that we're meeting with and caring for. And we can typically do same-day admissions or within 24 hours. That being said, of course, ideally, in a perfect world, we've had a conversation beforehand and we're kind of ready for this, and you don't have to make spur-of-the-moment decisions, but we all know that that's not how things go all the time. And again, we'll meet you right at the hospital and get things going. And if your goal is to go home that day or the next day, we can work with you to support you at home, provide equipment to support you at home, and get whomever your loved one is, again, ready for support at home. I'm trying to think of the last thing. I'm watching the clock too. I'm the rambler for once. And then we have bereavement support that's available. We can do pre-bereavement, so when someone first comes on services, then of course post-bereavement for the family that's remaining as someone's journey comes to an end. We have volunteer services, and something relatively new that we are offering, I don't know about other agencies, they may as well. We have a program called the 11th Hour. It's that no one should pass away alone. So there are people who, even if they live in an assisted living, they don't have family that comes to see them. With the staffing as it is, they don't have staff to sit with someone as they would pass. So we have volunteers that will come and remain at bedside in the 11th hour for that time as well. Yes?
Sorry to ask you.
No, please
I
do.
signed papers for my wife Friday afternoon for hospice.
Mhm.
Sunday, she had a seizure,
Okay.
and the home called the ambulance. And as they were in, I was now there.
Mhm.
I just happened to mention to the EM that I had signed papers Friday afternoon, put my wife under hospice.
Yeah.
And he said, he stopped whatever he was doing, so you better call hospice to make sure that she's either on it or not on it, because if we take her to the hospital and she's on hospice, we could have an issue. So the question that I'm asking, once I sign that paperwork, is she under hospice right away?
She is under hospice right away. So you did it at a facility she lived at?
Yeah.
Okay, not to go, there's a couple rabbit holes, but at the facility she lives at, yes, when you sign that. How that should have gone is the facilities reach out to hospice and let them know there's this scenario going on with your wife, for example. They should have called hospice. That being said, are you her power of attorney?
Oh, yeah.
So that being said, you as the power of attorney can still say, I know she's on hospice, but I want her to go to the hospital. I want her to do that. And we sort that out on our end. So it might be, there's some scenarios where you actually don't have, again, a lot of rabbit holes, where you can go to the hospital and you wouldn't have to come out of hospice. They're pretty rare, but that you wouldn't have to. There's some where she would have to come out, so maybe they took her in, she got checked out for whatever was going on, they got it under control. It's paperwork essentially. They would take her out of hospice for that day or whatever that looked like, put her back in. There's not a penalty or anything like that for Medicare. Hospice mentality, of course, the goal wouldn't be to be doing that constantly, but there are scenarios. Hip fractures is pretty common where they'll want to come out of hospice, get that hip repaired, and then come back on hospice. If our nurse is available and they get that call, they'll actually try to meet you at the emergency room, if available.
Thank you.
Yeah, of course.
Anything else?
Oh, sure.
He was the smart one out of the group. He's done this a time or two.
Hi, I'm Jason Wynn. I own Shuta Funeral Chapels, and we have a chapel in Stevens Point, and then we have our Plover Chapel also. Obviously, I'm not a Shuta. I did purchase from Dean Shuta back in, not everyone knows, but December of 2021. So he entrusted me to carry on the Shuta legacy. Not much has changed with the ownership change, other than the name of the sign still the same and so on. We still see Jim Shuta, who started almost every day, come into the funeral home, get his mail and so on. So that legacy still continues in the area. And obviously, I'm probably the one people least want to talk to or talk about, because I'm the end. I know there's parts of the road that you can skip, but we all have to, unfortunately, face death, something we can't avoid. But we're here to service you and your families, whether you choose us, Pizarski's, Boston, somewhere else, in a different area. There's a lot of options and great funeral homes in the area, thankfully, to serve you and your family. We'll do all sorts of services, from cremation with no services up to your full traditional services. We even do monk services at our Plover Chapel, everywhere in between. We also do pre-planning of services, so if you want to come in and meet with us to pre-plan your funeral, and you don't have to put money aside to fund it. You can just pick out everything you'd like to do, We'll have a file at the funeral home for you. If you want to prepay, you do have options to guarantee SHUDA's prices. So that way you can lock in our prices. Or you can do just to be determined, and that policy will actually gain interest over time. So a couple different options, and we have our pre-need specialist, Diane, who will kind of walk you through all those options and kind of set that up. And we also can assist you with monuments. If you do need a monument set up at a cemetery, we work with Marshfield Monument to go through those options too, because a lot of times it's nice to have that done because the cost of granite, marble, whatever it may be, that's going up and up and up and up. So it's nice to get that done ahead of time before it costs you more than it really needs to. And as far as the funeral service aspect of it, we kind of handle as much of it on our end as we possibly can. Filing of permits, death certificates. The death certificates, we try to be as efficient as we can on it. If the doctor signs off on the cause of death or a medical examiner and you approve all the information that we gathered for you, and the state doesn't reject anything, we've even had death certificates the same day as someone passing. Granted, that's rare, but we usually try to have the death certificates within that, by the service date or within a week or so. And I'll go to the register of deeds on your behalf, pick them up, and we'll have them at the funeral home, so you're not trying to figure out, okay, where's the register of deeds office, shuffle through the courthouse and so on. I'll just go get them, and then you just pick them up with me. Cremation permits we do at the file and so on, we get that from the medical examiner. We have an obituary writer on staff. She's a retired teacher, so you just have to get us the information, and we'll worry about the grammar and everything else. And we try to put a lot into that because it's it's your loved one's last story. So we try to put as much effort into the obituary as we can to make it as personable as possible. Along with the service, we work with a florist, so you don't have to run to a florist to pick out flowers. We have a book you can pick through. Obviously, order the casket, urn, clergy. We'll work with whichever clergy that or even try to find clergy. Like I know there's a lot of great chaplains with hospice. Brian Iverson or Chaplain Mark Lewis, they're fantastic. A lot of family members really like those individuals. I know they weren't brought up much, but they do have chaplains. Yep.
Mark is.
Yep, yeah. Well, he's highly recommended. Yep. And then whether we do the service at our funeral home or at a church, we've done them at bars or wherever they may be. Outside venues, Schmeekly, we've done a service there and did something at the amphitheater there. I've done visitations at Buchel Park with the casket, and then we went to church the next day outside. So whatever your requests are, and if it's possible to have done, we'll do our best to make it happen. And if you have any questions, feel free to call us anytime, preferably not too late at night. We don't use an answering service, so if you call the funeral home, you're going to get me, our other funeral director, Aaron, Diane, or Kirsten. And if you don't, it's just a voicemail. Usually we're on the other line and we'll call you right back. You're not going to get some operator from out of state or out of the country trying to find a director. I know the hospice nurses like that because when they call SHUDAs, they get somebody at 2 in the morning. We'll answer. So, and does anyone have any questions?
It says you put that beautiful on the front.
Oh,
that is a car stopper, right?
Thanks.
I texted him the other day, I'm like, wow, it looks really good.
Like a golf course,
we use a mower that they use to cut like the greens.
Yeah.
I like grass, I'm kind of a nerd on that. And it's a big strip down Highway 66, so I appreciate, we want to put that effort in when people are going by, that they see something beautiful,
It does look nice.
Thank you, yeah, it's a lot of work, but we try our best to make it look nice for our community. They put the bike lanes in, a lot of traffic, people going to the clinic and different offices. So, yeah, I appreciate the kind words. Thank you.
Well, speaking of, one thing I didn't mention, when you start talking, I kind of go back and forth.
That's fine.
Regarding, so some of loved ones that would be on hospice may pass in a facility and they can assist with calling our staff. If someone were to pass at your home, at your residential home, you would contact our nurse, but then they take it from there. They will contact the funeral home to, some people want family, they're coming in from out of town, they're on their way, they're driving, they would prefer that their loved one remain in the home for a bit of time, a couple hours or something like that. But whatever that is, we make that phone, or not myself, my nurses make that phone call for you.
Yep, and talking about their nurses, all the hospice that I've worked with in this area, and I've worked out of state before too, but it's just, the home hospice is really incredible here, the best I've seen in the Midwest, and I've been probably about all over the place in my career. So we're very lucky in this community to have that, to keep people in their home, because I mean, a lot of times their loved one built that home, or they've been on, that street, for, 50, 60 years. So for them to be able to be there till the end is, very important, and I'm thankful we're in a community that offers that, so. Yes.
What happens if I prepay, pre-plan, and that funeral home closes?
So the money that's prepaid does not go into our bank account. It's held into an insurance policy that's transferable anywhere in the country and even into Canada. So there's a lot of laws and regulations about funeral home billing, prepay, and so on, and we adhere to all of that. So to answer your question, hopefully we never close, but if a funeral home does close or change hands or whatnot, it's all transferable. And if you decide to switch funeral homes, which happens, somebody moves here, or vice versa, they go out of state, those policies are transferable, so. Hopefully that answers.
All right, so now that we've gotten to the absolute end, is there any questions for anybody on the panel?
There wasn't much mentioned about VA. Is there any interaction with the VA in all these groups or not?
So hospice, there's a
specific program that the VA offers veterans, if you have, of course, VA benefits, called concurrent care. I honestly can't speak to if every agency works with them or not, I don't know. I know that we do, and we work very closely with the VA, where there's additional benefits that are provided to our to our patients that work with the VA. And in some scenarios, they are able to do things where on traditional hospice you could not, such as palliative chemo, different type of hospital stays, different types of IVs that may be set up at home. It's all specific to the person, but things that they wouldn't do on traditional hospice. If you're a veteran, that's always something I ask when I'm meeting with somebody, or I might notice on their hat or in their home or something. Yes, for us.
And as far as VA benefits as at end of life, obviously with the DD 214, the discharge paper, which we're usually able to get from the Portage County VA's office. There's obviously the military honors, specific benefits as far as plaque and stuff like that. Mike and Dave from the Portage County VA's office, they like to work, they won't work with us, they'll work with the next of kin of the veteran who passed away to go over their end of life benefits, because it could vary veteran to veteran, which kind of, thank you for bringing that up. I know in the past, pre-COVID, we've had them come to the Post 10262, the VFW, and we did a seminar there with Mike, and that was really good. Actually brings up a good idea to maybe try to do something like that again.
Yeah, since COVID, we haven't gone back because obviously COVID happened.
Things changed, but yeah, he went over a lot of benefits, and it was a really great turnout.
It was eye-opening me. I have a father that's a veteran, and I had no idea most of those. I always thought you got a flag when at the funeral. Like, I legitimately did not know about some of the benefits, and now I've got my ear tuned to that. I mean, my father's very young, he's still only 58, but at some point, I'm gonna be looking into VA benefits, so now I kind of have a better understanding of that as well. So, yeah, that's a good
The VA has their own, it's kind of like their own little insurance area. So things that you wouldn't necessarily do with a traditional Medicare or Medicare HMO goes out the window with VA. Depends on, what kind of veteran you are, of course, but like home health wise, with traditional Medicare, we can't be in a skilled nursing facility at the same time, or we can't have another home care agency at the same time. With VA, if they're authorizing it, we can have both in at the same time. So there's different, it's a big rabbit hole that you can go down, but there are lots of benefits that a lot of veterans don't know. So I would encourage that you ask that. No matter who it is on this panel, we all know each other and are able to help with that. So if you're going to your, financial advisor, ask. She can move you to whatever direction she needs to for those benefits because they are out there. And I think that's a huge thing that most veterans don't know.
The VA comes out every year with a book about that.
Oh, yeah.
Well, yeah, are you gonna sit there and read it?
There's a lot of benefits.
There is.
Even for your spouse.
There's really good spousal benefits as well.
Yep.
So,
Yep.
I know the concurrent care is, it's maybe been around about a year now, but relatively new. And when I was first hearing about it, it almost sounded, I hate to say too good to be true, but all these extra things that are available because the VA is paying for it. So step one is identifying that you have those benefits available, and all of your professionals will know kind of where to go from there.
A lot of what drives, I think, all of the in-home plus assisted livings is the insurance of it. And each one has a loophole or a clause or a way to navigate that all of us should know someone that can help with or know the answer to that you necessarily wouldn't. So it's just asking those questions and being upfront honest, There's certain things in payers where, your Medicare benefit isn't primary, it's secondary. And you would think that it would be primary, but it's not. So it all depends on the plans that you're on, and it all depends on this, wherever you're sitting on that road map, right? So it's always asking those questions.
Just to add, for a skilled nursing facility, you have to be contracted with the VA. The VA
Correct.
requires you to sign a contract and be contracted with them in order to come to a facility.
Yep.
So I know that, and I've worked in many places, a lot of places around here aren't contracted. I know we are not at the Portage County Healthcare Center. I can't tell you why, I've only been there for 6 years, but I know other nursing homes that I have worked in for 20 years, and yes, I'm not as old as I look. Truly, it has to be contracted, and that is really frustrating for us as well, the nursing facilities, because we want to take and be able to do that, but it really requires a lot of paperwork and a lot of things to be able to get that contract. So again, primary means, if you're Medicare and VA, well, yeah, the VA will pick up, that co-insurance if you're Medicare, but it won't pay for you to stay private pay or stay under long-term care because we don't have the contract. So, and that probably is for all you guys contracted.
I think a lot of it too depends on your amount of disability.
You're right on. Everything is based on your plan and what you have true. But at least we're all willing to work with you guys. So you're right on. Doing good.
Thank you.
I do have a question, and it is my turn.
Oh, yeah.
I'm putting it here. So, loan closet, is there anything you guys don't take anymore, or do you have a list? Because we get a ton of calls, and I get a ton of people, and that's a lie, I get a lot of people, not a ton. But really wanting to do things, sometimes we can, sometimes we can't, sometimes, do you have a list or an updated list?
Well, okay, so first of all, the best person to ask is Hope at the front
Okay,
desk.
I can do
But
that.
yes, things have
Okay.
changed where we don't take certain medical
Equipment?
supplies,
Okay.
yeah.
The health and the book also.
Yeah.
The magazine.
Yeah.
Okay, good.
So it's best
Alright.
always to call and ask.
I'll double check. I thought as long as you brought that up.
And sometimes, storage is an issue
Well,
here,
yeah,
so
right.
we may have an overabundance of walkers, for an example, and,
Okay.
so it's always good to call and ask first.
Okay. And that power of attorney information, so if I say, like, I put my son and my daughter on my power of attorney papers, do they have to be there to witness it? So they can have it, because, okay, all right. Because sometimes I find, just a small problem where I put my daughter on and, I'll just use myself as an example, and then, I get activated and she comes in the nursing home going, yeah, no, I don't want anything to do with that. They didn't ask me, or things changed, I moved out of state. I want my brother to take care of that stuff. But they do not have to be notified if they have their name on it. Is that true or not true and signed?
Yeah, so years ago, there used to be a spot on the document where the healthcare agents would sign saying they accepted that position. That never was something that made the document legal. I think it was a place to encourage people to communicate, right?
Okay.
Secondly, you do not want your healthcare agents witnessing your document, because then the document is not valid. So on the witness page, there's very detailed, specific things about who can and who can't witness. When you meet with me or one of our facilitators, and same with Marshfield, because they go through the same training we do, we're going to really encourage you to have talked with your loved ones ahead of time, or make sure you talk to them after the fact. And we're also going to make copies for you to give them your advance directives so they know where it is, so they can look at it ahead of time. But what's most important with these the document is the legal piece, but what really helps the most is having those conversations. And it's not always fun talking about, my husband's a speech therapist. We used to work in the same facility, so him and I have crazy conversations all the time, but we've worked in medical. But it is important to say, if what happens, if what happened to Aunt Patty happens to me, I want things different. And your kids or your loved ones are going to say, I don't want to talk about it, and it's important to say to them, we need to talk about it. Because in the end, it's going to make their job easier. Also with meeting with one of us that have been through the facilitation training, we're going to help you start sorting through things that you may or may not want, and we're going to get that down on your document to serve as a guide to your healthcare agents so that they know what their loved one wanted. And it helps take that pressure off of them. So they can, my big personal worry is I don't want all my finances spent so my family's left dry, right? So, and that's just the way I am. My husband doesn't agree with me. But they know, my family knows that for me, I'm going to worry more about spending all the money. And so I may want things to not be done as long as other people. And that's okay. And then I have that written out. And then that eases the burden on them, that they don't have to make that decision. I made it, and they're being my voice. So we do talk about all of those things, which thank you so much for bringing up. But yeah, it's important.
So I have a question for you. My husband and I had a will drafted, and in that we had a estate plan and all those things. And the lawyer asked us all these medical questions. If I am in a coma, do I want to remain in a coma for a while? Do I want him to turn it off? Those types of very difficult questions. Is that an advance directive? It sounds like it is, but I never had it signed by a medical professional, which it sounds like I just heard you say a little while ago. So does that qualify?
Yep, it does qualify, and it doesn't need to be signed by a medical professional to do that. So I'm assuming that your attorney asked you who you would want to make those decisions for you. And then that attorney, in my opinion, went above and beyond, which is wonderful. Because they were asking you to get down some of your wishes.
Yes, some very tough.
Yes.
We also have a secondary medical. If, let's say, my husband's my medical. Let's say we're in the same car crash together. Yep. Who is my backup? Yep. So we even have that scenario laid out.
Yep, and we will encourage you often to have more than one person named. what happens is, so you have your first person and then your backup, and sometimes then even your third backup. Sometimes what happens is people are not able to make medical decisions for themselves. They may be like that for a couple of years, and their spouse, who was their healthcare agent, passes away. If you don't have a second person named as your healthcare agent, then we have to do the guardianship. So sometimes I will call, when I notice patients have an advance directive they handed in and they only have one person, I will reach out to them and explain the importance of maybe having another person added. And so then we kind of walk through that and talk about it. Because it is important, especially at that time, because you're already dealing with a lot of things.